and also currently a member of the Medical and Dental Board of the HPCSA. And she also serves on our Clinical Health Committee at Clinics Health Group. So tonight she's going to be talking to us about Paediatric Informed Consent 2024. And it's a pleasure, Prof. Lundgren, to welcome you once more by popular demand to come and give a talk at this webinar this evening. Thank you very much and welcome.
Thanks, Dr. Bila, and good evening, colleagues. No, I can't change slides. Why can I not change slides? Oh, there we are. Colleagues, what are we talking about? Just to define what we mean by children. So we're talking about people under the age of 18. And I've divided them up into 3 groups. So we have a child who's older than 12, but less than 18, a child who's younger than 12, and a pregnant child. The only other group of children is a child not of sound mind. And I have not included this in my talk because it's falls under the Mental Health Care Act to some extent, as well as a different part of the Children's Act. So I'm basically going to concentrate on a child of older than 12, and less than 18, a child who's younger than 12, and a pregnant. So first of all, the legalities. Which laws are we referring to? And we're referring to the Constitution. Previously, we had the Child Care Act. So please don't ever be guided by the Child Care Act. That is old. We have a very modern, up-to-date Children's Act, which was promulgated in 2005 and only enacted in 2007. The National Health Act also refers to children, especially the Tissue Act section of the National Health Act. And then we have our Choice on Termination of Pregnancy Act from 1996. The ethics of informed consent in children is the same as in adults. And one is talking about patient autonomy, which is ruling oneself. So autos is self, nomos is to rule, and it implies liberty and capacity. And one can ask the question, do children have the right to decide for themselves? Yes, they do. And our job is to interrogate and decide on whether the child who you are going to treat has the capacity to do this. And that's quite tricky. So another ethical issue is that we need to have respect for this autonomy, despite the fact that one is dealing with a child. Doesn't mean you just hand over a consent form to the parent, guardian, caregiver, whoever, override the child's rights, and that is how you get consent. You need to decide whether this child is able to give consent. And I'll go into that in more detail. So one needs to obtain informed consent to tell the truth. So there's full disclosure. As in adults, it includes children, full disclosure. One needs to protect their confidential information and respect the privacy. And the confounding factors affecting decision-making, particularly in children, are anxiety and immaturity. And our Constitution states a child's best interests are paramount in every matter concerning a child. And that's, if you don't remember anything from this talk tonight, please remember, a child's best interests are paramount in every matter concerning a child, and that includes whatever medical treatment, whatever consultation one is performing, whatever anesthetic, whatever surgery. it's the child's best interest. And it sounds very straightforward, but in fact, it can be quite complicated. And quite a few years ago at Barrow, we had a child in ICU, teenager in ICU, and the parents they lived up in northern Limpopo. It was often difficult to get hold of them. The father didn't always agree with what the mother wanted, and there were a lot of issues with this child. The child was in ICU for considerable time. A lot of specialties got involved. And after a couple of months, decisions had to be made as to where the child should be transferred to, what we should do with the child. And there were so many specialties involved that they called in the head of bioethics at WITS to help guide the decision-making of this child. And why am I telling you this? Because it was fascinating listening to this. At every step of the way, the head of bioethics would say, okay, neurology spoken. Now, what is in the best interest of the child from the neurological point of view? Then we'd go to cardiology, and what is in the best interest of cardiology from this child's point of view. And we went from specialty to specialty, and eventually a decision was made of what was in the best interest of this child. So it's not always a straightforward decision, yes, no. And very often, if it is a complicated case and there are a lot of different specialties involved, at every step of the way, one needs to take a step back and look at what the best interests of this child, the best interests are with this child that you're dealing with. Oh, apologies. This is very strange. Okay. In the past, we had the Child Care Act, and I mention it just so that please don't ever be guided by the Child Care Act, where we had a minor over 18 may consent, any minor over 14 may consent, and then a child between 14 and 18, you needed the child's assent. With the Children's Act now, the age was lowered to 12. And why was the age lowered to 12? The age was lowered to 12 because of the number of child-headed households. I'm talking now way back in 2005. As you all know, a lot of adults died of HIV, and there were many, many child-headed households in our country, and there still are. And so it was felt that the age should be lowered to 12. And so in the Children's Act, and this comes straight out of the Children's Act, a child of 12 years and of sufficient maturity may consent to an HIV test. Similarly, HIV disclosure. Consensual sex, they're capable at 12 but only mature enough at 16. Consent for medical treatment, 12 years and of sufficient maturity. And consent for surgical treatment, 12 years and of sufficient maturity. And if you ascertain that that child's sufficiently matured to understand the surgical treatment, the child gives consent and the parent, guardian, or caregiver gives assent. So the Children's Act states exactly this. A child may consent to his or her own medical treatment or to the medical treatment of his or her own child if the child is over 12 and the child is of sufficient maturity and has the mental capacity to understand the benefits, risks, social and other implications of the treatment. And bearing in mind that the National Health Act has similar wording for adults, benefits, risks, social and other implications. So it's our job to have to ascertain this child's maturity and mental capacity. And I'll share with you what our Health Professions Council guidelines state in this regard. From the surgical point of view, a child, and remember, medical treatment can even include bone marrow donation. It can include all sorts of things, blood transfusion, chemo, etc. So medical treatment is very, very broad. Surgical treatment is obviously surgical procedures. And similarly, a child over 12 of sufficient maturity and mental capacity to understand the same things, benefits, risks, social, and other implications, and the child is duly assisted by his or her parent or guardian. And if the child is mature enough, the child signs consent, the parent signs assent. If the child isn't mature enough, the parent or guardian signs consent, and the child signs the assent. One needs both signatures. So what does it mean to ascertain the maturity and the capacity in a child? And this is incredibly difficult. I mean, I look at my grandchildren. I've got a 12-year-old granddaughter who wouldn't be mature enough, and I've got a 14-year-old grandson who knows it all, been there, done it, could quite easily give consent for a surgical procedure. So it varies. It really, really varies, and it's often very difficult to decide. The HPCSA recommendations are that we need to decide on the child's capacity, whether to consent to or refuse a proposed investigation or treatment. And in general, the HPCSA states a competent child will be able to understand the nature, purpose, and possible consequences of the proposed investigation or treatment, as well as the consequences of non-treatment. Remember, as with the National Health Act with adults, you're obliged to give an adult the option of not to have the treatment at all and what will occur if they don't have the treatment. The same goes with a child, and this comes out of the Children's Act. And our assessment of a child needs to take into account the following. A minor with sufficient maturity over the age of 12 years can be treated as an adult. And we all know we have, 14-year-olds going on 21, and we have 14-year-olds who act like 10-year-olds. So it's our job to decide on the maturity and capacity of that child. And if you decide the child is sufficiently mature, that you treat them as an adult and legally competent to decide on all forms of treatment and medical and surgical procedures. And as we all know, it often depends on the child's life experiences. And what our courts have said, and this also comes from the HPCSA, our courts have said that legally for proper informed consent, the patient must have knowledge of the nature or extent of the harm or risk, appreciate the nature of the risk, and consent to the harm or assumed risk. And the consent must have been comprehensive. And it's very important. If one speaks to the bioethicists, it's very, very interesting because they always point out its material risk. So what do we mean by material risk? What is a material risk for you if you become a patient? And a material risk is a risk that a reasonable person in the position of the patient, if warned of the risk, would attach significance to it. You may die, you may be paraplegic, you may bleed a lot, etc. And it stated that the healthcare practitioner should reasonably be aware that the patient, if warned of the risk, would attach significance to it. So it's very important that we talk about material risks. And then which risks should we be discussing? With adults or with children, but especially with children, it's advised that, known risks should be disclosed when an adverse outcome is common, even though the detriment is slight. You may, from our point of view, you may wake up with a sore throat. You're having a hernia, you might have a bit of pain. or when an outcome is severe, even though its occurrence is rare. You may die. You may be paraplegic. So one is obliged to discuss all the risks, be it a child who's mature enough or an adult. And some people will say, I don't want to know, don't tell me, just do what you have to do. Do the medical treatment, do whatever. Remember that that invalidates consent as it is no longer informed. So that's not okay if the patient says, I don't want to know. Now, who obtains the consent? And the HPCSA states this in their consent, the ethical booklet on consent. A healthcare practitioner providing treatment or undertaking an investigation has the responsibility to discuss it with the patient and obtain consent, as the practitioner will have a comprehensive understanding of the procedure or treatment, how it is to be carried out, and the risks attached. So that's incredibly important. They also state where this is not practicable for the healthcare practitioner to take the consent themselves. And remember, we talk about children now. The healthcare practitioner may delegate these tasks, provided they ensure that the person to whom they delegate is suitably educated, trained, and qualified, has sufficient knowledge of the proposed investigation or treatment, understands the risks involved. And I've said, be careful of applying this in the case of children. You know, for you to say to your assistant or to an intern, if you happen to be in a public hospital, you go and get the consent. Does that intern understand all the possible complication or all the issues concerned with that treatment, that they can get informed consent and not just, this is what we're going to do, sign here. So it's very, very important, and especially in the case of children. And remember that the healthcare practitioner remains responsible for ensuring that before he or she starts any treatment, the patient has been given sufficient time and information to make an informed decision and has given the consent to the investigation, treatment, or procedure. So we don't just rush it and say, here, sign here, you need X, Y, and Z, like we used to do in the bad old days. You know, a patient who needed a Caesar, I'm your doctor, I know what's good for you, please sign here. That is not acceptable legally or ethically. So patients need time and children need time. If the child is not of adequate maturity, even though if they've over 12, then the parent needs to be informed, or the guardian or the caretaker, and I'll share with you some guidelines on who is able to give consent for a child. But that person needs sufficient time to be able to make the decision and be fully informed. In the Children's Act, it states that the superintendent of a hospital or the person in charge of the hospital, in the absence of the superintendent, may consent to medical treatment or surgical operation on a child if the treatment operation is necessary to preserve the child's life. Only under those circumstances. Remember, best interests of the child. If the parent or guardian refuses or cannot be traced, or if the child unreasonably refuses. Now remember, you're acting in the best interest of the child, you're the advocate for that child. Then it's advised that one goes to the courts or the Minister of Social Development. And I've said in bold letters, remember the child's best interest. People suggest legal advice, but that often takes a long time. And just to state that, you know, the courts, there isn't a children's court in every city, town in this country, but magistrates' courts can function as a children's court. They have a function that they can speak for a child. So one mustn't be alarmed if one doesn't live in a big center where they have a children's court, etc., etc. One has access to a magistrate's court and can get hold of a magistrate who can make a decision in the best interest of that child. But remember, if it's an emergency, the superintendent or the person in charge of the hospital can give consent if it's going to save the child's life. Now, this is a very, very useful document, and it's the 5th edition. It's dated December 2013, which is old. And I've looked for a more recent, updated edition. It was written by a couple of people at the Children's Institute at UCT, and it's absolutely fabulous document. If some of you are online and you work only with pediatrics, and you wonder sometimes about who can act on behalf of a child, this is an absolute must. And I've been asked before about parental rights, particularly for surgery, for anesthesia and surgery. I'm an anesthesiologist by training, and at Barrow, we often had issues where the mother of the child, the biological mother, wasn't married, and the child and the mother had different surnames. And these were day cases that came in, and the nurses were in a quandary. Can they accept this mother's consent? Even to the extent of, how do we know that this is the mother? And there were lots of issues. And this document is amazing in explaining not only the consent provisions, and as you can see at the top here, I'm looking at chapter 6, which is the consent provisions in the Children's Act, but it deals with all sorts of issues pertaining to the Children's Act. But it basically says that when both parents have full parental rights, either parent may consent individually to medical treatment or surgery. However, where decision could significantly change or have an adverse effect on the child's health, the person giving consent must take into consideration any views and wishes expressed by any co-holder of parental responsibilities and rights. So, in other words, the other parent. So it's better if both parents are on the same page and agreeing, particularly if there are going to be major effects on this child's life and health. And adoptive parents have full parental responsibilities and rights. Now, what is interesting in the difference is the difference between biological mothers and biological fathers. The biological mother of a child, whether married or unmarried, has full parental responsibilities and rights, unless she's under 18 years. And then her guardian is also the guardian of the child. So remember that. The Children's Act deals with children from 12 to 18. So if you have a child who's between 12 and 18, the child's guardian needs to be involved, whether it's a mother or grandmother or whoever. And so if this young mother has a child, the granny or whoever her guardian is needs to be involved in decision making. Biological fathers is very interesting, that the biological father of a child has full parental responsibilities and rights in respect of the child if he's married to the mother of the child or was married to the child's mother at the time of the child's conception, birth, or any time between conception and birth. However, in the case of a divorced father, the court order drawn up at the time of the divorce will indicate which rules apply with respect to guardianship and care when it comes to the child. So it's very interesting that this doesn't apply to the biological mother. It only applies to the biological father. And for unmarried fathers, the situation is slightly different. That's the old laws. The Children's Act has changed the law so that an unmarried father who is committed to caring for his children can have equal parental rights and responsibilities without having to approach the High Court. The old law said the unmarried father had no rights, but the Children's Act has changed this now. And Section 21 of the Act says the father has full parental responsibilities if he's living with a child's mother at the time of the child's birth in a permanent life partnership. And regardless of whether he's lived with a mother, he can also acquire rights if he consents to be identified as the father, if he contributes or attempts to contribute to the child's upbringing. I don't know what a reasonable period means. And if he contributes or has attempted to contribute in good faith to the expenses in connection with the maintenance of the child. So fathers have more rights under the Children's Act than they did under the Child Care Act, but there are certain provisos. And if there's any dispute, and in cases where the unmarried father doesn't acquire rights and responsibilities, he can enter into agreement with the mother, but that's got to go through the High Court. So biological mothers have more rights in the case of the child than biological fathers, but the Children's Act is kinder to biological fathers than the old Child Care Act was. And remember, a caregiver is anyone who cares for the child, and it includes grannies, aunts, foster parents, temporary safe carers, the head of a child and youth care center, a child and youth care worker mentoring a family, or a child heading a household. So caregivers is very, very broad. And I think when I think back on when I was at Barra and the interrogation that a lot of the caregivers, guardians, even unmarried mothers got when they brought the children in, the day cases in for their procedures, it would have been useful to have some guidelines drawn up of who constituted the child's guardian if it wasn't a biological parent. So I really recommend these guidelines to anybody who's dealing with children all the time. When does one apply to the court? To the children's court, or in the case of a small town that doesn't have a children's court, the magistrate's court? If you doubt the patient's capacity or what is in the best interest, get more and you've consulted more experienced colleagues, it may be a good idea to apply to the court. If it's a controversial issue, remember things like Jehovah's Witness cases and similar, and particularly if the child's younger than 12 and the parents are withholding consent for life-saving treatment, it's advised one approaches the court. But remember, and this is cautionary in the Act, if the healthcare practitioner applies to the court, the patient must be informed and allowed representation, and if not the patient, the parent guardian. Now, I can't give a lecture on informed consent in children without mentioning the Choice on Termination of Pregnancy Act. And we need to remember that a pregnant female of any age may consent to the termination of her pregnancy, and her identity must be confidential. And if it's a minor, so under 12, she is advised to consult with her parents, but doesn't have to. And I've summarized here that if the pregnancy is less than 12 weeks, all pregnant females are fulfill the criteria for termination of pregnancy. If they're between 13 and 20 weeks, there are a few conditions in the Choice on Termination of Pregnancy Act. If they've been raped, if there's a risk of injury to the mother of the fetus, or for socioeconomic reasons. So those are fairly broad indications for termination of pregnancy right up to 20 weeks. If the pregnancy is more than 20 weeks gestation, the termination is only okay if the mother's life is in danger, if there's a risk of fetal injury, or if there's a severe congenital malformation. So I've abbreviated it into one slide, but basically up to 20 weeks, a pregnant female of any age just about can acquire a termination. Now, what about the paperwork? And one can ask the question, does there have to be a consent form for whatever you do? Chemo, blood transfusion, whatever. Does there have to be paperwork? And it can be verbal, but if it's verbal, we're advised to have a witness. And not anyone related to the patient, an independent witness, and then write it in the file in detail. And that's often the case with trauma patients or things like that, where there's no one around to give the consent, and one gets telephonic consent, then put it on speakerphone and have a witness and write it in the file in detail. But the HPCSA, along with the legal profession, always recommends written consent, if at all possible. And there's a lot of paperwork around, and some of it is really not legal consent. Dr. Bila will remember the days at Barra, how we fought with Gauteng Health to get a proper legal consent form, and not the old Transvaal Provincial Administration, old-fashioned, terrible consent form. And eventually we won, but it took years. So what paperwork is around? Every practitioner in the private sector administering medical treatment of any kind or surgical treatment should have their own consent forms. And remember, if it's in the case of children, which is what we're talking about tonight, you need a space for either the child or the parent to sign consent, and either the child or the parent to sign assent, depending on the child's maturity and age. If that child is over 12, it's very hard for some parents, if that's a mature child of, say, 15, they can sign their consent, and the parents got to sign the assent, and that's often very difficult for parents to accept, but it's the law. And a lot of the private sector hospitals have got a confirmation of consent form. It's meaningless. It's the patient's own words of what they think is going to happen, and it's honestly not an informed consent form. And if you work in the public sector, please make sure you've got an updated consent form. This is a bad slide, but it's the old TPH consent to operation, and only the top part of this first page. This is the entire consent form. This is the particulars of the surgery, and this has got nothing to do with, this is about RHTing and discharge and all sorts of things. And this is not a legal document. Likewise, this is the Mediclinic example of a confirmation of consent. This is what the patient thinks they're going for, and it's not a legal consent form. And all the clinic groups have got their own confirmation of consent form. The minimum requirements of a consent form, and I've been involved in designing, first of all, the consent form for Gauteng Health many years ago. And then I've, during COVID, changed a consent form to include risk sharing between the patient and the doctor for consent, and all of them go through a legal process and the ethics department. But the minimum requirements of your consent form, whatever practice you're in, should have a doctor section that the doctor says, I confirm I've explained the investigation, treatment, operation, etc. to the patient, parent, guardian in a manner that takes into account the following in according with the Children's Act, and then you write the procedure and the complications, etc. And then the second half is where the patient or the parent or the guardian say, I confirm the doctor's explained all of the above to me, I understand what I've been informed about, and I accept the risks associated with giving either my consent or assent. And please have two places on children's consent for the consent and the assent. So in summary, consent must be informed. I mean, it's in the law, it's in our constitution, it's in the National Health Act, it's in the Children's Act, and it's in the HPCSA ethical guidelines. Written consent is so much better, and the doctor giving the treatment or performing the surgery should obtain the consent. Remember, particularly in children, and I can't emphasize enough that you, the doctor, are the one who, if you're going to perform the procedure or give the treatment, you're the one who's got to ascertain if that child over 12 has sufficient maturity and capacity to understand the treatment. So that's why it's incredibly important that you are the one to obtain the consent. And then as I stated in the Children's Act, children over 12 with sufficient maturity can give consent for medical treatment. And remember, if they're mature enough, they don't need their parents or guardian. It's nice to have the parental or guardian assent, but it's not a legal requirement. And then if they're needing surgery and they have sufficient maturity, the child will consent for anesthesia and surgery, and the parent or guardian or caregiver will give the assent. If they're not mature enough, it's the other way around. And a reminder that a pregnant child of any age can consent to TOP. Thank you.
Wow,
Happy
thank you very much, Prof. Lundgren. Quite a comprehensive and I think detailed information. Some of it, I think, quite helpful. I think not so obvious to most of us about children, and it's quite been an important topic to ponder on and to listen. And yeah, remember those days when we were drafting that consent form with Adbara. Maybe if you share the latest one with the COVID, just for all of us to see. And you mentioned that in the private sector, it looks like you mentioned 2 hospital groups. So generally, there's a problem there in terms of informed consent, because unlike in the public sector, it's everyone does it one document, but the private sector, there are variations because different surgeons have their own form of consent. How do you address this going forward?
It's very, very difficult, and there are no guidelines, specific guidelines as to what your consent form should look like. And last year we did an audit in one unit at the Donald Gordon, and we just audited, and what we looked at was, is there a section that the doctor signs that he or she has explained whatever they're going to do, whatever treatment they're going to do, and then the patient says, I've read this, I understand, I've been given the option to refuse treatment and the consequences of that refusal, etc., etc. So, and in fact, all of them were very compliant except for 2 in this one unit, and that made us design a generic consent form, which has got those requirements, the doctor bit and then the patient bit, and that's exactly how we designed that Gauteng Health consent form. 10, 12, how many years ago, was the doctor section and the patient section. And I mean, you need to, if you're a surgeon who's going to be doing amputations and that sort of thing, included in the doctor section needs to be, the sentence about the disposal of limbs or tissue or whatever. It needs to be included in that. So there's no specific template, but you need the doctor section and you need the patient section for your individual practice.
Sure. Yeah, it's tough. Whilst in the edge, one of the questions is way down. There's someone who was working at Dial says they don't have the latest informed consent form. Can you share a link to that one?
Gosh, what have I got on this funny screen?
I don't know. I'm seeing lots of emails.
Yeah, I'm too. Dr. Bila, I don't. I last saw the Gauteng Health consent form. Oh, it was a long, long time ago. I don't know if I've saved it in my consent file. I'm happy to have a look, but you know, it's got the doctor section first and then the patient section underneath. But I'm happy to look for it in my consent file. I didn't think I'd be asked that tonight.
I didn't. Yeah, I thought everyone is using the latest one. So I'm told that they're
I
still
can't
using
believe the Transvaal consent form. That is just awful.
Yeah. Okay. Yeah. I see John Vetboy. You have a question? I see your hand is up. John, if you can unmute yourself. Can we just allow John Vetboy to unmute himself? Whilst he's still struggling.
No, it's unmuted.
Yeah, he's okay, go ahead, John. John, go ahead.
Sorry, I made a mistake.
Go ahead. Yes.
Sorry, I made a mistake.
Okay, thank you. All right.
Dr. Bila, I didn't say consent at 12 to 6. I said what is stated in the Health Act, and I'm sorry I didn't make myself clear, is that a child is able to have sex at 12, but it's consensual sex. It's illegal if it's under 16. Consensual sex. Remember, rape is not consensual sex. The word there is consensual sex. And it's 16.
Okay. And then the question is, what informs or ascertain that the child under 12 or under 18 is mature enough to take decisions? Is there a standardized test to reach that conclusion?
No, there isn't. And it was very interesting. One of our consultants, who sadly now emigrated at Wits, did he did an MSc in health law and bioethics, and he did his master's research report on capacity and what the determinants are of capacity. And quite honestly, as the HPCSA says, it's very often life experiences and the way children are brought up. I mean, some children are really, they're 14 going on 21. I mean, they are very mature in their understanding. They've been exposed to TV, to reading, to books, etc., etc. And there are 14, 15-year-olds who are terribly, terribly naive and so those are easy to decide. If you have a doubt as to the child's capacity, then obviously one needs to go to the parent, guardian, or caregiver.
Okay.
But yeah.
What if the father is below the age of? I think you covered it about.
The 18.
The father is below 18.
It's the same as applying to a mother. It would be the father's guardian.
Yeah, I think that was covered. Maybe a comment about Jehovah's Witness. You made a comment. We will be getting someone from the Jehovah's Witness to give a talk sometime next month, I think on the 20th of July. So we'll have that discussion in detail, but you did cover it. I don't know if there's anything that you want to add.
The layman's consent form is not valid. The Children's Act guide is online. I showed you the picture of it. It's online and it's very, very comprehensive. It's incredible.
Yeah, I think I would love to have a copy. Yeah. If we can get a link on that, I think we'll share with everyone. Yeah.
The contraception, a child less than 14, gauge the child's maturity. If you gauge that they mature enough to understand what contraception and the complications of contraception are about, then that's okay. And they don't need to consult with somebody as long as you assess that they're mature enough. Okay. Dorenko's asked me a very long question.
There's a question here. In a case where a child is seen in the emergency room with an acute abdomen, for example, and a consent is obtained for a laparotomy and a diagnosis is made during the process, does one proceed or close up and only proceed when the detailed consent is obtained?
No. Where's that question?
It's right at the top. I think you've
Right
gone
at the
down.
top. Okay.
Yeah, yeah.
Mm,
As in the
Uh,
Molauzi. A child is seen in the emergency room with an acute abdomen, for example, and a consent is obtained for laparotomy and a diagnosis is made during the process. Does one proceed or close up and only proceed when the detailed consent is
No,
obtained?
you proceed in the best interests of that patient. You proceed, and remember, all consent forms and usually have the clause I consent to a laparotomy and any other linked procedure or related procedure that is deemed essential to my well-being or something. It's in the consent form. So no, it's no point doing the laparotomy and not doing the whole.
When you find
No.
something, yeah, you
As
continue.
long as it's in the best interest, I presume we're talking about of the child.
Yeah. Now you were reading this one from Terenka. We had a
Yeah.
situation where a 14-year-old was booked for an unruptured ectopic pregnancy at night. That's not a dire emergency, but urgent enough that it cannot wait for hours. Her maturity was questionable. She was anxious. The parents were unreachable towards the morning. The gynaecists were worried that the child's condition is getting more serious, although not yet imminently life-threatening. It was decided that they would get consent from the superintendent. However, no one could get hold of the superintendent on call for the period of a few hours. The thought goes through one's mind to approach a magistrate. It was then that I realized that we are always taught to go to the magistrate, but no one ever teaches you the actual logistics of how you do this. What do you do? Would you phone? What about at night? She decided to consult my indemnity company. My phone call reached someone in the UK who had no idea about South African law. Luckily, by this time, they managed to get hold of the parents. But before you answer that question, I thought you could get a senior surgeon.
No, that's not.
It's no longer applicable.
That's an old wives' tale.
Is it?
Yeah, no, really, it's nowhere, not in the National Health Act, not in the Children's Act, not in the Choice of National Pregnancy Act. In this circumstance of Dorinka's question, it's actually shocking that a hospital manager or the superintendent is not available. And I would suggest that because if the superintendent's not available, somebody who's managing the hospital can give consent under those circumstances if it's in the interest of saving that child's life. Now, Dorinka says it wasn't that urgent, but it was imminently life-threatening. So, for me, the manager of that hospital, who was at that time managing the hospital, should be giving the consent. And how I get hold of a magistrate, Dorinka, I've never had to get hold of a magistrate at night. I know in Joburg, the Children's Court has an advocate on call 24/7, although I'd never personally tried to contact the advocate. And if one's going to get hold of a magistrate, I don't know. I've often thought that our hospitals and our provincial hospitals should have a system where who do you phone for consent? You know, this is the magistrate's number, this is the after hours call number, etc. But I'm not quite sure how we get hold of a magistrate.
At least in Gauteng, if there is no, you can't reach a hospital manager on call, there's always a superintendent or clinical manager on call.
Yeah,
But then if you can't get one, there is one who's on call for the whole province. It's called a medical managing officer. So that person should be able to give you consent. Because
yeah,
it's
that's
standing
right.
in for
That's
that
right.
person is standing in for they
That's
you'll
right.
be able to find someone. It's impossible not to get anyone at night. There is always someone who's on call for the whole of Gauteng, who is a
Well,
medical
that's
doctor.
what, yeah, exactly. That's what I was thinking.
Yeah.
A lot of requests to share the slides. I will. I just want to PDF the presentation and I'll send it to Dr. Vila.
Yes, yeah. Now, Yasmin Dockwart says, if a baby is born under emergency 0 section, close to full term in APGAR score of 0 for 10 minutes, manual resuscitation, non-prolonged internal bleeding to the mom, how does a doctor make the decision on whether to resuscitate the child or not, knowing that the lack of oxygen and is likely to suffer brain damage? How does a doctor decide on what is in the best interest of the child? Or do they
Yeah,
just try and save a life no matter what? Are parents meant to be asked in those circumstances?
well, ideally, one would ask the parents, and the parents would say, "Save my child's life." It's very difficult, but if you're saying it's close to full term, for you to judge under those circumstances that this child's going to be severely brain damaged, etc. I mean, the child, there are all sorts of circumstances. The child could be hypothermic. There could be all sorts of things that may preserve brain function. And I don't think you can make a decision whether to start resuscitating or not. You go for it and resuscitate the child. Because you can't stand back and make that decision at that stage under those circumstances.
Yeah.
I think we all should try and save the life, but ideally, I mean, parents are not going to think straight under those circumstances anyway.
Yeah, definitely. Yeah. Sure. We get into the winter season, lots of circumcisions. Parents forcing children under 12 to be circumcised.
No, the age of circumcision in the Act is 16, unless it's for medical reasons or religious reasons. So it's medical and religious reasons, and the age is 16, and the child should give consent. But
they should give consent.
Talking males, obviously, but parents shouldn't be forcing children under 12.
I've seen lots of children going to the hospital under 12 in the public sector, going to be circumcised. So they shouldn't be.
The Act, the age of circumcision is 16 for elective circumcision, and the boy gives his own consent. Circumcision in girls is outlawed, is against the law. But we're talking male circumcision, and a 16-year-old should give consent, and it's over 16. However, it says either for religious or medical reasons, and
Okay.
it's fairly loose. I haven't looked at that section of the guideline on the Children's Act, so I can't expand on that.
Okay.
When a minor gives consent to have a fetus incinerated, to parents have the right for return it.
There's a hand from Elani. Elani, you want to go ahead? Elani, please unmute yourself. Come, are you allowing Elani to unmute?
Can you hear me?
Yeah, no,
Yeah.
sure, go ahead.
Okay. Now I just want to double check to make sure. So if there's a life-threatening situation, it's probably been covered. Can the super or the clinical manager then override the parents if they decide? If the parent says no, and the child's not going to make it, are they allowed to stop the parents?
That's when you try and get a magistrate opinion, or you get a more experienced person. You can get, I mean, even the head of an ethics department or a bioethicist can intervene at that stage. If you can't get hold of a magistrate, or the Minister of Social Development spokesperson, but that would take far too long. I mean,
Yes.
you know, it's very difficult if the parents, are you talking about a child over 12 or under 12?
Probably any age. If a child is
Yeah.
obviously mature enough and he can override his parents, but
He can override
if
his parents,
yeah. But then if the parents say no and the child says no and it's a competent situation and you know it's detrimental or, you know, even I
Then
think
you
worst
must,
case scenario.
then you must get a court to intervene.
Yeah, it must be
You
a court
have
order,
to,
yes.
yeah, you've got to
Oh,
get a court to
okay.
intervene. It's
Okay.
tricky. It's very, very difficult.
Yeah,
Yeah,
difficult. Okay, thanks for that answer. Appreciate.
Okay, consent to take videos and pictures. No, it's not okay. It's not okay. Remember putting photos and things like that are not de-identified, and well, first of all, taking videos and pictures of children's medical conditions. Did you get consent from the child or the parents? And if you haven't got consent, you are breaking the POPI Act, and sharing on social media equates to publishing. So be very careful of what you share on social media. I remember Harriet Etheridge, who was part of our bioethics department, gave a superb lecture a couple of years ago, and it equates to publications. So no, you need consent. And if you have consent, it needs to be de-identified, but on social media and doctors' chat groups, not okay.
Yeah. When a minor gives consent to have her fetus incinerated, do parents have the right to overturn the decision?
I don't think so, no. No.
So they can, yeah.
Because the
Okay.
child doesn't have to have told the parent she's going for national in the first place.
Yeah. You feel it a bit there, I don't know. I think there's one about how do you determine child maturity? Use psychometric tests?
No, you don't. You know, it's very, very difficult. That's why I say you get the 14-year-olds going on 21, and there's no question they can make their own decisions. And then you get the 14-year-old who has the maturity of a 10 or 11-year-old. If you're not sure, then get the parental consent, but get the child to assent. And you know, the child's assent is incredibly important. We had a little boy at Barra many years ago who had a torsion of a testis. And I think he was 15 or 15, and his mother was an ICU nurse, and she had signed the consent. The kid came to theatre and was terrified. And he said, "What are you going to do to me?" And they said, "No, we're going to, give you an anesthetic and operate." He said, nobody's touching me. You even put a drip up on me, I'll get it off the table.
Sure.
And they phoned me and said, "What do we do?" I said, "You take him off the table, you send him back to the ward, and you talk to him. If he's mature enough, he signs the consent, his mother assents. If he's not mature enough, his mother assents, he consents. His mother consents, he assents. But he needs to understand what's being done to him. He's 15.
Yeah,
and they did
yeah.
that, and a couple of hours later he came back and for the surgery. So, it's wrong to treat children as if they don't understand.
Okay. If you are going to do multiple procedures, do you need more than one consent?
No, one consent can cover the multiple procedures.
You're
If
feeling
you're
a
in
little
an
bit there.
ICU scenario, coming backwards and forwards for relook laps or dressing changes or whatever, if you're in an ICU scenario, the consent is okay as long as you've said relooks and reapplications of dressings, as long as the patient's condition hasn't changed in the interim since consent.
So the initial consent is sufficient?
As long as that patient hasn't changed condition. So if they've had an arrest and other things have happened, then it's not valid. Then you need a new consent.
Okay. And what if a child refuses to take epilim due to side effects?
If the child's mature enough, they need to be told the consequences of not taking their epilim. And an alternative treatment should be sought.
Yeah. Yeah, there's someone who spoke to, I think they're referring to the blood transfusion.
Yeah.
How long should a blood transfusion consent remain valid, especially for medical patients? Does the patient always have to sign when you give blood, or you just rely on one signed consent form during the duration of the patient stay in the hospital?
It's okay for the duration of the stay as long as their condition hasn't changed dramatically. So they haven't needed ICU admission, they haven't arrested, they haven't become unconscious or something like that. As long as their condition hasn't changed dramatically, the one consent should cover.
Okay.
But you can talk to the patient. You can say, I see you signed the consent. It's going to be the same again. I'm going to give you another unit of blood. I mean, you can also talk to them, and you've got the initial consent that's signed, and then you get verbal consent.
Yeah. Rory, pause. You want to say something? Go ahead, Rory. Sure, it's Peter. Unmute yourself, please. You're still muted, Rory. Okay, there, go ahead.
Perfect. Thank you very much.
Yeah.
First of all, thank you very much for a very interesting talk. The one thing that I've always wondered, because it's come up quite a few times recently, is the validity duration of the consent. Is there a difference between written signed consent, telephonic consent, either from the parents, from the superintendent, etc.? Because some nursing staff say that it's only valid for about 24 to 48 hours. Is there any legal standard on that?
No. So there's nowhere is it written how long the consent is valid for. But if you've signed consent for say for repeated blood transfusions, and so your original written consent is fine, as long as your condition hasn't changed, the patient's condition hasn't changed dramatically over the period of time. I mean, a lot of patients come in and need repeated blood transfusions, but their condition hasn't changed dramatically. They haven't had an arrest, become obtunded, or whatever. You speak to them and you can get verbal consent, but that original consent is still valid. But if there's any doubt, I mean, and that's why ICU is so tricky, and that's why in ICU a consent, like for Burns patients, they come back and back and back every second day. As long as their condition hasn't changed dramatically, that consent form that they originally signed, as long as it's a proper consent form, is valid. But if their conditions changed and they've become obtunded or whatever, then get a new consent form. But there's nowhere is it written how long it's valid for.
Yeah. Okay, well, I think the last two questions been quite an interactive discussion. I think the statutory rape, it looks like there's a lot of clarification sought on this.
No, so consensual sex, you need to be 16, and statutory rape is just not okay, because it mentions consensual sex, and that's an agreement of both sides. So, I mean, so how does a child of 13 get a termination of pregnancy? And in the conditions, or the conditions for terminations, even up to 20 weeks, is if you've been raped. So I mean, we live in South Africa, and it's a scourge of our society is rape. So the Choice on Termination of Pregnancy Act covers terminations for rape victims, but there's is statutory rape, and I would need to refresh myself on the Children's Act, but consensual sex is over 16.
Okay. Mulifi, go ahead, Mulifi. Your hand is up. Hi, Mulifi. Please unmute yourself, or come on, allow Mulifi to unmute himself. You're still muted, Mulifi. Oh, I don't know what's going on. I think whilst he's still struggling to unmute himself, can a parent override the child if they give consent?
No, not if the child's mature enough. No. The child's over 12 and mature enough and understands everything. Parent can't override it.
Okay. Mulifi?
Yeah, Molefi is unmuted.
No, sir, Ray, it is a mistake. I mean, I just raised my hand by mistake. Yeah, sure.
Okay, that's fine. No, thanks. Nice hearing your voice anyway.
Thanks, Ray.
And Tabiso, I hope it's...
Hi, good evening.
Hi,
Hi.
Tabiso.
Hi, thank you very much, Prof, for such an informative talk. I mean, sometimes these things are always in hindsight, especially when it comes to consent. We once had a situation where we had a 15-year-old boy brought by the mother with orbital cellulitis, and such things, obviously they are managed in conjunction with ENT guys, but you need to have confirmation. So while waiting for the CT scan, the mother decided to take the child home, insisting that he's going to take the child to a private hospital. To fast forward, to cut the story short, this child died the following day when he was brought by the dad, and it was already complicated sinusitis. Now, in regards of us, the doctors, what could we have done because at the time we didn't have confirmation that this is what is going to happen.
Yeah.
But we're in our right to say, no, don't take this child.
We had a terrible case with parents who insisted on faith healing and whatever for a osteogenic sarcoma that had the child had no knee left, and they couldn't walk properly, and the school referred the child for treatment, and the parents were not interested in Western medicine, and the child was mature enough to give her own consent, but wouldn't go against her parents. And it's, you didn't have a proper diagnosis. So it's very, very difficult to, what's in the best interest of that child. But if you haven't got a proper diagnosis and the mother says, I'm taking this child home, all you can say is this child is very, very ill and I advise you not. But if she doesn't listen to you, she takes the child home. And it's awful to see. And with us, I mean, we even went the legal route because of the best interest of the child. And we tried all sorts of things, and the child didn't want to go against what the parents said. And I mean, the child died. It was horrible. And it's you're in such a terrible predicament because ethically, legally, that you should be acting in the best interest of that child. But ultimately, that child could make up her own mind, but would not go against what her parents said. And it's an awful situation to be in, to know what's medically in the best interest of that child. But if the child doesn't agree and the parents dominate, it's incredibly difficult.
Okay. I think the last question, there was somebody that thought the hand was up. I'm not sure if you were still on to talk. The last question is not so clear, but I'll try to understand it. It says, does this apply to in a private to get consent for a child in an emergency? I suppose maybe in the private sector, do you also give consent for a child? Do you need to get consent for a child in an emergency situation?
Do you need to get consent? On emergency?
Yes.
Yes, you do. But remember, the hospital manager can give consent if it's life-saving, and you can't get, if it's life-threatening, life or limb, and you can't get hold of parent, guardian, caregiver, you then get the hospital manager to sign consent. And most private hospitals will phone their legal departments and they'll say, go for it. It's in the best interest of the child, go for it.
Not Prof. Lundgren. In terms of the National Health Act, because it defines the superintendent or hospital manager as a medical doctor, or is it always the case? Because
No.
in the private sector, you find that they are not necessarily medical practitioners.
No,
It
it doesn't
matter.
define. It just says the hospital manager or superintendent. It doesn't define if they have to be medical doctors or not. But then the parents are not medical doctors. So, but it doesn't in the Children's Act.
Okay. Sibuti Tsoteti, your hand is up. Go ahead, you'll be the last person. We are almost at 7:30 and we had close to 700 participants. And
Sure.
Sibuti, go ahead.
Yes. Can you hear me? Oh,
Yes,
Yeah.
I can.
Hello?
Yeah, sure.
Hello?
yes.
Yeah.
Yes, I wanted to find out is it right for the doctors to refuse dialysis for a patient who was once dialyzed, but because of not understanding what is dialysis, what is kidney failure, he ended up defaulting treatment, maybe twice. But the third time, when he was now understanding the whole thing about dialysis and renal failure, doctors refuse to
No.
dialyze him.
No, they can't refuse.
Punishing the patient.
No, you can't refuse.
Yeah,
Oh.
no, definitely.
But that's the parties that you see in state facilities where they'll set guidelines like who should be dialyzed.
Yeah,
should
with
not be
limited
dialyzed.
resources. Yeah. That's always the problem in a state facility.
Perhaps it's because they would say that, you've got limited resources. There are 20 patients and you one of the 20 or one of the lucky 15, and you're given the opportunity to have a dialysis, and you do not take advantage of that. And so by the time you come back, the slot has been taken over by someone that say, it's better to give it to people who understand, who are ready and prepared to dialyze. I think it's because of the limited resources that they have in the state. I've seen that. I've had people who, patients who also are difficult, and doctors would refuse to continue with dialysis for such patients, difficult patients. But I think generally nobody should be denied access to health.
Really? And then
are you talking to us or you?
no
Okay,
wonder
thanks.
also even number high. It was just
Sorry. Can you mute that person, Tikamo? Okay, thank you very much, Prof. Lundgren. This has been quite an informative session, and quite a number of people have logged in. I'm going to ask Professor Makunyane just to do the closing remarks. Prof. Makunyane.
Thank you very much. Thank you, Professor Lundgren. And quite a complex topic, and multi-layered, multifactorial, but thank you for handling it so excellently. And really, just from the number of scenarios, one can deduct that
we lost you. I lost you.
Yeah, I lost it too. I don't know, Prof. Makunyane. It looks like we lost it. Yeah, no, but anyway, thank you very much, Prof. Lundgren. It's quite informative. I think we, as I said, we almost 700 participants this evening.
Oh, there she is.
Are you there, Prof. Makunyane?
No, she's gone.
Yeah, so we'll have you back once more. I think ethics is quite
muted now. Sorry about it.
we
I
lost you.
was muted. Oh, okay, I see.
Okay.
No, thank you very much, Professor Lundgren. And yeah, a very complex topic, but thank you for handling it so excellently. And thank you so much to Clinics Health Group for this opportunity once more. Now, and yeah, especially those who, working behind the scenes to make it happen for all of us. And thank you so much and good night. Over to you, Dr. Bila.
No, thanks, Prof. Thanks a lot, sir. Thanks, colleagues. And
Thanks for
thank you.
all the attendees.
Yeah,
Thanks for the attendees.
thank you very much, Prof. Thanks, Kamu.
Pleasure.
Good night, colleagues. Good evening. Bye.
Thank you. Bye-bye.
Thanks, Dr. Bila.
Thank you. Bye.
Thank you. Bye-bye.